Hi, I'm Catherine Ayers-Wickenhauser, Director of Communications at Direct Trust, and I'm so excited today to be joined by Maria Moen from AD Vault, who has recently been named one of our interoperability heroes. So welcome, Maria. Will you introduce yourself and tell us a little bit more about AD Vault too?
You bet. Thank you so much. I'd be glad to. My name is Maria Moen. I am the Senior Vice President of Innovation and External Affairs for AD Vault. We are a digital advanced care planning, advanced directive technology platform. We are in over 50 countries, one of which is the US. And our mission is to ensure that when a person is receiving medical care in an emergency basis or due to a health condition or a health crisis, if they are unable to communicate for themselves, we can make their memorialized advanced healthcare decisions accessible to the team that is providing care so as to inform that care and treatment in a very personalized manner. Our founders are very passionate about this particular role, and we have enjoyed working with a number of organizations and health information exchanges and providers and health systems to really ensure that these memorialized advanced healthcare decisions are secure and accessible and available when they're needed, when seconds count and minutes matter. So I'm just very proud to be here today. Thank you very much.
Sure. You can certainly hear the passion in your voice. And obviously this is a super critical area of healthcare. And knowing that standards are really the building blocks to interoperability and thinking about how we put these pieces together, and knowing that HL7 is one of those critical organizations and standards development organizations. I'm curious if maybe you can tell us a little bit more about your work with HL7 and in particular, the Advanced Directive Interoperability with FHIR project.
I would love to. I'd love to share that with you. This particular initiative was brought to fruition, started in about October of 2020. So I think that there had been previous discussion and lots of initiatives that thought about, we should really address breaking the bonds of paper in this critical area. But, it's a difficult topic. It's a very multi-layered topic. And the stakeholders are just diverse. They are the provider community. They are the technology community. They are the policy, the standards community, the legal community. But one of the good things that we can pull from the global pandemic that changed the world as we know it was a very heightened sense of awareness that any individual, not someone who is necessarily older or who faces a critical health condition, but any individual could find themselves in a position to need emergency medical care and be unable to communicate for themselves. So we know that because these urgent treatment decisions can be made at times, the need to access advanced directive and advanced care plan information is an essential component to providing personalized, high-value care. And I think it created an appetite and an awareness on the part of the provider community and on the part of the millions and millions of patients and consumers across the US that this is not something I want to put off any longer. This is something that I need to, at the very least, designate someone to speak for me if I'm unable to speak for myself. And I could go a little bit further beyond having a conversation and memorialize for the medical team how I want that healthcare journey to go. What we learned and what we still know today is that the aging population receiving healthcare in skilled nursing facilities and assisted living communities were under forced isolation, and even now are experiencing a limited return to family interaction to reduce the risk of contracting COVID-19 and all of the variants that are emerging. During COVID, those requiring medical care found themselves during a transition in care without anyone to accompany them to influence medical care and be at their side. And the impact was and still is a tremendous sense of disempowerment, isolation, and a disconnection with the world that they feel that they can no longer safely interact with. Never before has the availability of verifiable digital advanced directive information been so essential to delivering care. Advanced directive forms and advanced care planning documents remain largely paper-based, which leads to numerous barriers and burdens and adverse outcomes. Erosion of trust in the healthcare system occurs when treatment is not informed by the individual's personal values and goals and preferences. And the role of technology and expanded adoption has brought to the forefront the expectation of seamless accessibility to this type of information. So we started this project to create the FHIR standards for interoperable data exchange, integration, sharing, and retrieval of this critically important information in October of 2020, working within the PASIO project, PAC for post-acute care, and IO for interoperability, which is a collaborative effort to advance interoperable health data exchange between post-acute care and other providers, patients, and key stakeholders across healthcare, while promoting health data exchange in collaboration with policymakers, standards organizations, and industry through a consensus-based approach. The primary goal of the PASIO project is to establish a framework for the development of FHIR technical implementation guides and reference implementations that facilitate this necessary data exchange through standards-based, use case-driven application programming interfaces, APIs. The MITRE group provides the leadership, structure, and technical expertise needed to bring the FHIR implementation guides to fruition. And PASIO is supported by MITRE, CMS, the ONC, and many, many other stakeholders. The ADI, Advanced Directive Interoperability, and that's an overarching term, and don't we love our TLAs, our three-letter acronyms in healthcare, is creating those standards for creation, exchange, and verification of personal advanced care plan and advanced directive information authored by a person or a patient. Now, historically, HL7 and standards have dealt with clinical data exchange. So it was an interesting journey to look at all of these FHIR resources and profiles and standards and to really change chairs from the perspective of being the clinician to being the patient. And there was no small amount of stretching and reinvention of some of these data aspects that occurred during our project. Now, in the start of 2022, we will move to practitioner-authored data to include portable medical orders for life-sustaining treatment and episode-centric patient instructions, such as an in-hospital DNR or DNAR related to that immediate treatment or procedure. Our work is informed by an incredible and vibrant community of healthcare professionals, EMR, EHR companies, personal health record companies. We have legal experts, we have industry thought leaders, and we have subject matter experts who have contributed an incredible amount of time and guidance. We are sponsored, this project is sponsored by the Patient Empowerment Work Group within HL7, which was convened in 2019 by HL7 to make sure that patient-focused issues would be appropriately represented in all of HL7's work groups. And their mission is to promote and amplify the viewpoint of patients and their caregivers in standards work with a specific focus on the patient perspective. Now, through the course of this project, we performed an exhaustive environmental scan of numerous existing advanced directive forms, documents, personal advanced care plan, forms, documents, platforms, because we wanted to derive a comprehensive content library against which standardized vocabulary codes either already existed due to previous work in CDA or that we ascertained, required creation to support the envisioned data exchange. We extensively reviewed and adjudicated content and concepts found within these forms and documents as a part of building this FHIR implementation guide that is now in ballot and available for implementation. The use cases and storyboards for each type of content we reviewed were modified based on learnings and results from real-world testing events called Connectathons in HL7 land. And the Passio community participated in the technical activities and the use case activities to ensure that the standards creation process met the needs of both implementers as well as receivers. And I think that that's a key differentiator. When you have clinicians and legal experts who are informing a project and saying, this is what I battle now, this is the problem that I need you to solve with technology, it was just a very enlightening experience. And we relied on that guidance and that input heavily. I know other FHIR IGs have been created in less than 14 months, but it was our passion and our commitment to this community that we would represent the voice of the clinician while enabling the exchange of person-authored information using the latest FHIR standards, which are fully supported by the ONC and their desire to escalate and enable good quality, robust data exchange. So we made every effort to enable implementation of digital advanced directives and personal advanced care plans across the US in all jurisdictions. We were focused on breaking the bonds of paper that have hindered us as an industry for over 30 years.
So incredible. It's just, I am awestruck by how incredibly important this work is, how timely it is. As you outlined, so many people have been in the position recently where they have been thinking about this and maybe they hadn't really thought about it previously. And, we could spend so long diving into the different milestones and activities that you just outlined, but I want to highlight a couple of things that you just said because I think they're incredibly important. One, knowing HL7 is a standards development organization, you really drove home that this has been a consensus-based effort and really thinking about all the different stakeholders. You mentioned those sending and receiving, and also the criticality of that information and what it contains and how important it is. And I love what you said about when seconds count and minutes matter. And then even breaking the bonds of paper, thinking about advanced directives and advanced care planning on the whole. You are so right. I mean, one of my first jobs was in a medical records room. And so, I think about to the back of the chart, the actual physical paper chart where those wishes would be, and how historically this industry has had a lot of paper, and how bringing it into interoperability and making it a standards-based approach is so critically important. So thank you for taking us through that journey. And it's incredible to think that so much of this has happened since October of 2020. So very cool. And thank you for leading that group and your efforts there. And so thinking about in general, maybe some next steps or what might happen next, or even in the present. So what challenges do you think healthcare organizations face in terms of implementing existing and emerging health IT standards?
It's a really good question. You can create all of the standards that you want to, but you then have the burden of implementation, adoption, and even an appetite to look at how healthcare has been conducted historically and how healthcare needs to evolve and pivot. We know that care coordination, when a person transitions between healthcare settings, and that can include ambulatory care, acute care, long-term post-acute care, and even home and community-based services, it is often fragmented, which can lead to poor health outcomes, massive amounts of increased burden, and definitely increased cost. An interoperable healthcare information exchange has the potential to improve patient and provider communications, and it supports access to longitudinal health information that enables improved efficiencies, improved quality of care, and improved health outcomes. Data should be usable across the spectrum of care and beyond the traditional healthcare system, now into the community. Patients and their caregivers are also critical exchange partners, and you might not think so. And yet, in this new world in which we live, if we are to make advancements in care coordination across healthcare, then patients and their caregivers have to be exchange participants. They stand to benefit significantly from digital applications that support electronics exchange of information between care settings. Those digital applications can promote patient-centric care through improved transitions and care coordination, including shared care through the belief that patients should own their own data. And if we empower patients to be active participants in their care by working towards ownership of their own health data, that can help them make informed choices about their care. And all of this leads to lower costs and improved quality of care, while improving the healthcare experience and the likelihood of better health outcomes by reducing potential errors from incomplete or incorrect medical history.
Mm-hmm.
Adoption of interoperable data exchange by technology solution providers, coupled with a desire by healthcare providers to access data across care settings as part of their own mission to deliver person-centered care, has been the driver for innovation since the onset of COVID. However, legacy workflows and processes, the natural tension that exists between risk management and clinical practice, and a reluctance to introduce additional changes to care teams who are already stretched thin, may create a perception that providers do not have the appetite for yet another technology initiative. But to think like that, you have to liken that dilemma to being so busy bailing out your boat that you're too busy to fix the hole in the boat. It's interesting to note, and I think this is one of the reasons that CMS and the ONC and so many stakeholders have contributed so much time and thought leadership. Did you know that spending for overtreatment or low value care in the US was between $75 billion and $101 billion, according to a JAMA article from late 2019. Now that's before we've added the COVID statistics. So, we know organizations favor a portfolio approach, right? Of informal collaboration with a broad selection of partners. I bring home health to bear, and I bring skilled nursing to bear, and I bring rehab and hospice and long-term care. And these partnerships do deliver a cost-effective access to a breadth of expertise without making a significant capital and resource investment. However, we also know that absent or incompatible electronic medical record systems, data, and information are still prevalent. We know that there is a lack of robust data analytics capabilities. There is truly poor communication with health systems. There can be a failure to recognize industry trends combined with a reluctance to embrace required changes. And I do believe that there are misaligned incentives. But we still have to march forward. We still have to continue to innovate and pivot and look at new ways of doing the things that we do. And that's how we will meet the expectations of the provider community, the needs of the people who are receiving care, and will really fulfill the promise that technology and interoperable data exchange just offers us.
Mm-hmm. And I want to dig into that more in a second, but with your answer and what you just described, so I definitely heard multiple times those threads of the quadruple aim, right? And especially outlining that significant overspending on on treatment and what that looks like. It's just unfathomable to think of and think how that might be counteracted with better data and information flow, and including the patient as part of that information source. So truly, hearing from your response that data and communication and involving the patient and their care partners and care team is truly critical to getting to that state. And what I want to know next is, how do you think that interoperability can enhance the patient experience and even patient engagement?
It has been our observation that people want to be more engaged with their healthcare. They know that there is digital data available. So we're seeing personal health records on the rise, which gives a person an opportunity to see their own information. We know that large EMR companies are creating patient portals that give those people who are receiving care a view they've never had of their history and their health information. And I think that ability to really bring the person into the care delivery system, not doing things to people, but doing things with people. That is the idea whose time has come. One of the things we did on the HL7 project that I should have mentioned was we worked really hard with a specific work group, and part of our FHIR implementation actually sets up a patient-authored care plan where the context or the problem is described if this were to occur. And then based on the person's responses, those populate the goals of the care plan. And then because provider care settings, and it can be long-term supportive services that are non-skilled, it can be skilled services, it can be acute, all of those different areas of the provider setting have different capabilities and jurisdictional policies and regulations. We left the interventions open. And the group that we worked with loved this idea. When you can take a treatment plan or a plan of care that was architected by a provider, here's what they've got, here's what I'm going to do, here's how I'm going to do it. And you can dovetail into it what the individual themselves has said. You have truly created a person-centric plan of care. And we did it in such a way that it will seat into existing medical record platforms and clinical record systems. So we believe that systems, specifically related to our project, systems used to create and update patient-generated advanced care plans through a patient-directed process needed a way for individuals to communicate information about their advanced medical goals and their preferences for care and their priorities, so that even if all you did was automate a 2-page advanced directive, out of 15 different treatment modalities a medical team might be looking at, knowing what is important to them, what makes a day worth living, what are the things that bring this person peace or comfort, what are their goals, that can narrow that list of 15 maybe down to 3. And at that point, the medical team can engage with a family member or a proxy or a patient representative. And so we know that this makes a difference. And individuals needed a way to generate this information related to what it is they want their healthcare journey to contain, so that those wishes could inform those provider-generated care plans. Interoperable exchange of advanced directive information, all health information, supports more effective sharing of that information across transitions and cares. And it enables the practitioners and the providers to create treatment plans that align with that person's values, their cultural, religious, spiritual priorities and preferences, their goals of care, their quality of life priorities when the patient can't communicate for themselves. So we truly are passionate about the work that we are doing, and we do it on behalf of the millions of Americans whose lives we hope to give a voice to.
it's incredible work. I mean, certainly, I think oftentimes working in this industry, we put ourselves in the patient's shoes because we are patients. But understanding that different people have different journeys too, and thinking about maybe what we've seen family members or friends go through, or people who perhaps have had more complicated journeys or even not. It's certainly critical work to engage patients. So thank you for sharing that information with us. And, as we kind of get to the end of today's conversation, I'm curious first, if you might describe, what do you think will be the next push for nationwide interoperability? So any predictions for the future?
Well, my crystal ball gets a little murky some days, but, it is my perception that we have officially entered an era where organizations are grappling with tremendous growth in the amount of data available, and they're struggling with how to manage and make use of it. I think that the expansion in the capabilities of providers to exchange data will drive adoption. The market drives change. And I believe that their needs will triangulate around two distinct areas of influence. So inside the organization, those providers are going to want more and more accuracy, availability, and ease of use. That will drive adoption. Information access has to be feasible for staff, and it has to be easy to dovetail into the existing workflows if already heavily tasked staff are to embrace the expansion of information when providing care and treatment. I think privacy, consent, and that staff's understanding of what those terms mean will also be important to continue to move data exchange forward into an expected feature function of their software capabilities. And when all of those aspects of interoperable data exchange can be accommodated, then the provider's burden of training is greatly reduced and the barriers to adoption are dramatically lowered. Now, outside the organization, we need to enable connections between provider organizations, state and regional information exchanges, qualified health information networks such as eHealth Exchange, Care Equality, Commonwealth, to name a few, to ensure that there is an infrastructure of secure, consent-based data exchange that enables access. This process is currently onerous. It is varied by application or data source, and it carries an incredibly high overhead. We have to ensure that providers have access to information about their patients in a way that is efficient for them to manage. Now, my perception is that this is going to be a disruption within the electronic medical record, electronic health record, and clinical record vendor community who deliver partial data in different ways. And this is going to necessitate a common presentation style where the data from inside the organization, the provider is responsible for the integrity of, is presented differently from the data outside the organization that is so necessary for continuity of care. But we need to make sure that this ability for the provider to ascertain this is the data that came from my organization, I'm responsible for risk, accuracy, liability. This is other data that has come in, and it is important to the continuity of care I'm delivering, but I need to be able to distinguish and access it easily. So we deliver, I believe that this delivery of data will protect the provider from the risk, liability, and allow them, this came from the outside, so it's inaccurate or it's incomplete. And this is what happened as a result of it. I think it will raise the alarms. And there's just one other kind of point I want to make. Transport mechanisms that are frictionless and they cross over from inside the organization to outside the organization because you've got the transport and you've got the receipt. And this area of influence means that technology companies have to enable the retrieval and the presentation of that outside information in a secure and seamless manner. I think identity verification and authentication of the person accessing and are creating the digital information as part of ensuring they are who they claim to be is going to emerge as a new deliverable for health data access. Healthcare organizations need to have confidence that the data that they access from outside their organization is for the person that contributed or authored that information, or about the person who is right there in front of them that they're treating. And I think identity verification is an approach that can begin to address this need. I think digital identity verification is becoming the foundation of our rapidly evolving, technology-based, data-driven healthcare system.
Very cool. And thinking about my experience too, working with providers and accessing information interoperably and incorporating that into the record, I think what you touched on of having some way of distinguishing, but having a commingled record, but something where you can distinguish is very smart. I think that will certainly alleviate some of that stress that providers face. So I think that's a wonderful prediction. And obviously, you know, direct trust, we certainly, we are all about our foundation of,
Yes.
of trust and
Yes.
identity verification. And this is an area that we definitely are diving deeper into, as are many other organizations, because as you outlined, it's critical. We need to know and trust the people that we're exchanging information with, and that it's accurate, and that we can trust it. So I think those are tremendous predictions. And with that, I want to know, Maria, any final thoughts, any words of wisdom?
Oh, I recommend that providers identify this appetite and this need to access as much information as possible about the treatment that they're providing. When they raise these needs, when they advocate for themselves, and whether that's with technology partners or whether it's other partners within the healthcare system who are fighting their own barriers, when the market rises and says, it is not optional, I need to have access to this information, it is cost effective, it gives the best treatment, it delivers the best outcomes, and I should have access to it, that's when we're going to see the industry start to change. The market will drive the migration. So I encourage the providers who watch this to stand up and to demand access to the information that you need. And I encourage the technology providers to take a look at data exchange and interoperability with new eyes. Put yourself in the worn shoes of these healthcare heroes who have been out there caring for people through a global pandemic, and lean in, listen to what they're asking for, and innovate like the providers have innovated. And I think we will come together, and it will be a new healthcare system.
Definitely an optimistic outlook. I love it. I love it. And again, I want to congratulate you on being recognized as an interoperability hero. And thank you for sharing your work with us today. And so if you're interested in watching more spotlight interviews like this, check out directtrust.org/Interop Hero.
Thank you so much for arranging this podcast and for allowing me to speak, for our project and all of the hard work that we've undertaken and will continue to undertake. And thanks to all of you who are out there fighting that good fight and still battling COVID. And, you know, we appreciate you. You can call me an Interop hero, but I think it's the people with the boots on the ground that are the real heroes. And I'm just honored to be a part of this spotlight. Thank you.
Absolutely. Thank you, Maria.